Write the note. If you are consulting by phone, document your assessment, your reasoning, and the specific triggers for recontact. Orders without narrative are not a consultation. 2 sentences can be the difference between a defensible chart and a chart that requires you to reconstruct your reasoning at a deposition table 4 years later. 2. When the scan does not match the mechanism, expand the differential. Bilateral hemorrhages in a 20-year-old after a low mechanism fall should trigger a question. The question is whether the mechanism could be more than just trauma. Could this be a thrombotic event in a young patient we have not yet fully characterized? At a minimum, pause and review what could cause this pattern on CT if we remove the fall. That pause leads to additional emergent imaging, and it might identify a diagnosis the initial trauma framework was never going to reach. 3. Consider hormonal contraception when the history leaves doubt. In this case, oral contraceptive use was never confirmed on the record. The parents did not know their daughter was taking any medications. The patient's sister raised the possibility during the hospitalization if a young woman with unexplained intracranial hemorrhage has hormonal contraception on her medication list, or if the history leaves a question. That could be a differential shaping fact. A 5 to 7-fold increase in cerebral venous sinus thrombosis risk. It should change the imaging you order, not just the counseling you provide at discharge.